Hello, hi, good morning, good afternoon, good evening for all of you who are joining us. I'm Carl Blanchet. I'm the Director of the Health in Humanitarian Crisis Centre at the London School.
Hello, I'm Adrienne Tester. I'm an Associate Professor at the London School of Hygiene and Tropical Medicine. We'd like to say a big welcome to everybody for joining our course on health and humanitarian crises. We've had a phenomenal response, both in people joining the course and also fantastic responses in terms of your engagement questions, sharing experiences and engaging with one another throughout the course. We've been really amazed at having 14,000 learners across the globe, and people have registered from about 190 different countries, so we've been really impressed with the response. And it seems fitting that we should, in our final week of the course, have this Google Hangout where we have a chance to interact with you and to respond to some of your questions. We'd also like to thank you for these questions, and unfortunately we're not able to respond to all of them, but we've picked a select few and we hope you're one of the lucky people that had a question selected. So we'll start off with our first question, and Carl and I will do our best to answer them, respond to them, and also have a discussion and reflect on the sort of discussions that you've brought up. Okay, so to start off with, our first question is if we could share something about our own experiences in refugee camps or locations with a high number of IDPs and describe the standards of healthcare that are available. So Carl's going to kick off with that.
Kick off with that, okay, great. So yes, I used to, one of my first experience in the humanitarian sector was to work in the refugee camp of Ngara in Tanzania, just after the genocide in Rwanda. And we were actually providing healthcare and rehabilitation services in the camp. And that was one of the first experience as a very young humanitarian or relief worker. And more recently, I've been involved in a few studies in Lebanon, in a few settlements amongst refugees in Lebanon, and as well in refugee camps in Greece. And there's an ongoing study as well on migration and sea mortality in Italy. But basically, refugee or forced migration is one of the key priorities of the Crisis Centre in order to respond to the Syrian crisis, obviously, but as well because there's a lot of gaps we need to understand and how to better deliver services. And more, we have new challenges. So what I have experienced in Ngara in Tanzania a decade ago has nothing to do with what I've been seeing in Greece and Lebanon. In Ngara, basically we were dealing with basic services and infectious diseases, looking as well at security issues, because there were a lot of suspicions that many of the refugees were actually some of the people who had committed crimes in Rwanda. So there were a lot of security issues we had to deal with, and many tensions within the camp. As in Lebanon, we are dealing with non-communicable diseases, and these are new interventions for us as humanitarian actors. We don't have many protocols. We don't have all these kits ready to be deployed and ready to be delivered, as we used to have in some of the low-income countries. And some of the interventions we are dealing with are very new for us, and we need to introduce many innovations to make sure that we are effective. Unfortunately, there's not much evidence on what we are doing, and there are a few studies going on NCDs, but for sure that delivering healthcare and NCD interventions in new settings and middle-income countries is probably quite a new challenge. Another one, we're going to talk about that, but it's all about urban settings. So basically, what we have in Greece and Lebanon is we have people who do not live anymore in refugee camps, as we used to have in Ngara, for example. So basically, it's very hard and very challenging for us to identify where they are, identify their needs, and making sure that they come back to services when they need to come back to services for follow-up or for other constellations. So we have quite a few challenges, and to be honest, what I have experienced 10 or 15 years ago, it's basically I'm in a very new situation, and I'm learning new aspects, and we need to adapt a lot of the interventions we used to implement.
I've had experience on both sides of the Somali border. So, for example, I've spent time actually in parts of Somalia where there's a significant IDP population, as well as refugees and voluntary migrants that are passing through northern Somaliland and Puntland as part of the migration process over to Yemen and into Europe. The work that I focused on there has been largely on HIV and sexual and reproductive health. And this is an area that sometimes is neglected and seen as not quite so important or life-threatening immediately as other aspects of healthcare. The other place where I've also had experience is across the border in Kenya, in the world's largest refugee camp, which is Dadaab. And that's been in the news quite a lot recently. And again, the Kenyan government is threatening to shut the camp down. Currently, there's over 300,000 people living there, most of who are Somalis from across the border. There's a lot of issues and tensions there, and some of the course with the Domis camp case studies that we've used were very much founded in that sort of experience. So when Carl and I were talking about things like the tensions between the host population and the refugee population, they're very much rooted in reality and experience, not just in Dadaab, but across many different places. My experience in that case was that there seemed to be a perceived and a real inequity in terms of healthcare provision. That part of Kenya is extremely deprived of national services, and the population there feel very much that they're not paid attention to. This is in tandem, side by side, with developed and specific healthcare interventions and other forms of service delivery to the refugee populations, and it's seen as being very inequitable and very unfair, and there is a constant management of the relationship between the host and the refugee populations. In that sense, we've certainly seen case studies where it's increasing that there is some sort of kind of access for host populations where newer and better services come into play. I think in terms of the work that we do and the work that I've done, it's made actually implementing research incredibly difficult. And in one setting that I was in, it was actually supposed to look at HIV vulnerability and risk amongst both refugee populations and the host population. And in the end, over issues of fairness was being laid out to all parties, it wasn't possible for the host population to be included, which was an incredible shame. And it really highlights that the management of those relationships is incredibly important in humanitarian crises, and it does affect how healthcare is delivered. I would say in terms of work that I've done within Somalia, I found that there was an incredible willingness and energy from government and ministries and NGOs working there to really improve things. But I think the insecure and unstable situation, the ebbs and flows of action of insurgents and militias really does impede that. And I think one of the notable things about Somalia is that MSF will work pretty much anywhere under any circumstances with any groups. Their mission is to provide and support and implement life-saving care. But their workers actually became targets, and I think that quite sets some of the Somali context apart in terms that they did pull out, and I think that was very unusual. So I think I'll leave it there unless you have a question or
No,
something
no,
to
just
add.
just something to add about the tensions, because that's a very interesting topic. The tension between refugee populations and host population. And what we have in the humanitarian sector, we usually target refugee populations. What we are seeing more and more in the most recent crisis is that the national authorities are putting more and more emphasis on more geographical interventions rather than group-specific interventions. So they're asking humanitarian organizations such as the HCR or the international NGOs to actually provide services to refugee population, but as well to include vulnerable population. So in Lebanon, for example, the Ministry of Health is asking all the humanitarian organizations to include all the poorest Lebanese into the interventions where they work, in the areas where they work. In Greece, for example, where the country has experienced a financial crisis and where Greek population have to pay, there's an out-of-pocket payment of 50% of their expenses needs to be paid by Greek populations. And on the other side, refugee population have access to free healthcare. So what the government is actually asking, how can we actually have a more equitable distribution of resources, making sure that Greek population can also benefit from this kind of humanitarian intervention.
Great. Okay, I think we'll move on to our next question. So the next question is, do you feel that the UN is still effective in response to humanitarian crises, and has it now become a bit of a toothless tiger? That's a nice one for you, Carl.
Is this for me?
Or shall I start?
You can start if you want.
Okay, so there's often a lot of criticism about any humanitarian actor, whether they be UN or NGO or private foundation or government or whatever. And we have to remember it's very easy to criticise. A situation of crisis is just that. There are very few wins, and a lot of the work is trying to prevent death, prevent illness, and you're never going to be able to achieve all of that. What we're trying to do is minimise deaths, minimise illness and impact on people's lives. So it is very easy to criticise, but we've also got to recognise that we have to have some vision of what a success is and what a win is. One of the things that has been recognised in the past, and over the last sort of 20 years, there has been reform in the humanitarian sector, is that coordination and leadership have been really critical issues, and the lack of having those components in a response has led to inefficiencies and ineffectiveness of the response to a crisis, and lessons have been learned over time. One of the things that was done around that was that the IASC then developed a cluster system, and we have alluded to that in the course, and it's one of the components in week one. And it, of course, we're most interested in the health component, but it actually covers lots of different areas. So it will look at things like protection, education, water and sanitation, health. And WHO is the lead of the health one. This has made improvements in terms of the responses. It's led to better emergency preparedness planning and a better understanding at the local level of who is responsible for what, or who should be responsible for what, and to have a kind of map of what the resources are, who does what, who can do what in the event of the onset of a crisis. That's a more ideal scenario, and different countries are at varying levels of preparedness. At the same time, we've seen where things haven't gone well, and the clusters haven't responded necessarily in the way that they needed to. And one of the more recent things that have been quite heavily criticised is the WHO response to Ebola in West Africa very recently. I think Carl will probably talk a little bit more about that. So I think what I would say is that the cluster system's there in order to not just have cohesiveness and coordination amongst the UN, but also other international actors. But we also must remember that the scenarios are actually becoming much more complex. We're seeing the complex emergencies of where we have both natural disasters alongside insecure conflict settings. So even right now we are looking at responses to the pending famine in South Sudan and in Somalia and in northern Nigeria, all of which are settings that are experiencing drought, but at the same time it's in a setting of insecurity and instability, so it's incredibly difficult to respond. Having said that, I don't think that we can say things cannot be improved, and also we do need to ask the question, what is the alternative if we don't improve and use the system that we have? And I think Carl will probably talk a bit more about that.
Right. Yes. I think I've never been very kind with the UN agencies, and we published quite a few papers that we could share later on the net, on BMJ and others, on WHO, for example, doing Ebola, and a lot of criticism has been raised after the Ebola crisis, that's for sure. The thing is, today, what I've seen during the last 15 years is I've still seen quite a lot of improvement. And yes, as you say, there's a lot to improve. The thing is, I can't see any alternative for the moment. We need a WHO, we need an OCHA, we need a UNHCR. So I think they need to exist. They need to be better, but we cannot say, okay, let's get rid of the UN system, which I used to say 10 years ago. I don't think that's the right solution. What we need to do is to reform the UN system within the inside. I think it's very important to actually put the right people at the right place. And I think it's one of the big criticisms that we highlighted in our papers, is that it's very important to put the very competent people at the head of departments and doing the right job. Because when we have the right people at the right place in the UN agencies, we can do a lot. Because when they talk or when they invite people to a workshop or to a meeting, we have all the officials who cross the world and come to this meeting. 10 days ago, I was at a technical group on SRH in emergencies organized by WHO. We had people flying from everywhere. They have this kind of authority to be able to create consensus around a common project, a common idea. I think that's very good. We are going to look at the new emergency department of WHO, and we have a lot of hope. And there are some very good people there. And we hope that they will be able to introduce all the reforms and new ideas and innovations that will improve the UN system. So I think for the moment we have a lot of expectations and a lot of hope as well. So I don't think we can get rid of the UN system. We can improve it. I think it's our job as academic, as civil society organizations, as journalists, to continue to put pressure on this UN system, making sure it is accountable to us, accountable to populations, accountable to governments, but as well to make sure that they are transparent. And that's very, very important. We've seen a lot of improvement. UNHCR has published a lot of data on twine, for example. That's fantastic. We can analyze this data. We can make sense of all the data they have collected. That's a huge improvement in the UN system. It's very, very important. More and more you have NGOs who are part of the dialogue and are invited by WHO to discuss about new guidelines, to discuss about new strategies. That's very important. It's a huge improvement as well. We understand, they understand that now the system, the Humanitarian system is made of UN agencies and government and donors, but not only that, not only these actors, as well all the civil society organizations, the activists, and the humanitarian NGOs. So that's very important. So I think we're going to keep an eye on the UN agencies, and we're going to make sure we're going to support them because we need to improve this system anyway.
I think one thing I'd add to that is part of the support is also being evidence-based and using research. And I think that one of the things we talked about in the course was the challenges of conducting research in humanitarian settings, but also how important it is. And it's really to be able to see is what is going to save the most lives and improve the health of people that are affected by crisis. And I think that brings us quite nicely onto the next question, which is what is the role of the minimal initial service package and how is it implemented in conflict situations? So the minimal initial service packages is specifically for crisis settings, and it's really aimed at life saving. So, for example, in sexual and reproductive health, whether or not there's a crisis, women don't stop having babies and people don't stop having sex. And the sex may be voluntary or involuntary, and really the role is to provide a package that can respond to people's needs. Part of what that is that, as we've seen in the course, is that there is often where conflict breaks out, an increase in sexual violence against men, women and children. And women and children in particular tend to be very vulnerable. And having a package that has a pillar focusing on responding to the consequences of sexual violence is really important. So rape kits and being able to provide psychosocial support for survivors of sexual violence. Also things like taking care of pregnant women, women who are delivering and their newborns. It's an incredibly vulnerable time. I think in the Ebola crisis there was a story of a woman giving birth in a tree. I mean, you can't think of someone more in need, and also the not only the sort of physical needs of her and her newborn, but also the psychosocial support that might be needed. Also, the sorts of things that need to be in place are planning for services. As we see with some crises, many in fact, they're quite protracted, and there needs to be a planning there for family planning so that people can plan when to have children or not to, particularly if it's a situation that's going to go on for a period of time. I think perhaps Carl's got more to say on the MISP and a review of it.
Yeah, I think it's so the MISP is very interesting, but so we're currently doing what is very interesting is that WHO is actually reviewing all the clinical guidelines related to each component of the MISP, including abortion. And it's a very good initiative, and London School is part of this process. What is very interesting is that when we look at SRH or the MISP in general, or SRH, it's a huge mountain. And what I don't understand is that we are dealing with a wide range of professionals, between deliveries when we need to have midwives, nurses, and doctors, to family planning, which is very, very different. It's all about provision of services. We also talk about education. So for each component, we have a different set of skills we need to put in place. So under one name, we have a wide range of services. So what we're trying to do now with WHO is to make sure that we differentiate each of these components, making sure that the characteristics of each of them are well defined, and that we have some clear evidence on each of them. Because only talking about the MISP at all, as a whole, doesn't make sense to me. So new clinical guidelines, that's very much in the pipeline for the moment. What we're trying to do, there's a lot of guidelines, and we look at them, we could have a pile of guidelines already produced on SRH. There are a lot on in stable settings. So what we're trying to do now is trying to see whether these guidelines could be adapted to humanitarian crisis. And we're going to differentiate between the acute phase and the following phase, making sure that what do we need to deliver? Do we need to deliver abortion services during acute phase? Certainly not. There are other services that should have priority. But this is what we need to define. So that's going to be quite a long process. And based on this, we're going to identify and adapt the existing clinical guidelines. That's going to be very interesting. At the same time, WHO has asked the Crisis Center at the London School to actually review how the MISP was implemented. What kind of evidence do we have on the effect of the MISP in this kind of humanitarian settings? So that's going to be an interesting process as well. We are just starting now, but we are certainly going to keep you informed, and through the website and a few publications we're going to put online. That's going to be very, very interesting. Understanding as well what kind of obstacles we have to implement these kind of services. I was very surprised when I was in Geneva 10 days ago at this technical meeting to hear that within WHO, they still have to convince that SRH should be implemented during emergencies. I don't get it. I don't understand that. I'm so surprised about it, To me, yes, we have to do it. There's no question about it. How do we do it? That's another question. And what are we going to implement from the acute phase? That's another question to me. But yes, it has to be implemented. And we've seen that, as you said, during the Ebola crisis, how SRH services were crucial. We are seeing that now in Syria, where we have some data on deliveries, for example, and how and the risk for mothers to deliver in hospitals that are targeted. Yes, it is essential. And I'm very glad that WHO took the lead actually to put that on the top of the agenda.
Great. So I think what we're saying is that it's really a rights-based approach to sexual and reproductive health, and that being in a crisis setting is no reason not to be providing those services, which in many cases are life-saving and have a huge impact on people's lives during the crisis and beyond. Okay, so our next question is, are health interventions in humanitarian crises as effective in rural areas as in urban areas? So I think we need to kind of differentiate a little bit about that. In many cases, IDP camps and refugee camps can be in quite remote areas, often because there's the space, but they're probably not the best places in terms of access to water and electricity and those sorts of things. And increasingly what we're seeing is the shift, as we've alluded to in the course, of populations being much more enmeshed within urban populations as well. And I think Carl's going to talk a little bit about that, about some of the Middle East and Southern Europe experiences.
So we conducted quite a massive systematic review of health interventions in humanitarian settings, and there are many gaps a bit everywhere. But one of the key findings is that we do a lot of studies in refugee camps, and of course it's quite convenient. People, specifically the one we know or we experienced 10 years ago, where people were in camps hoping to go back to their country. Today we are in a very different settings where actually the borders of the camp are very blurry and are moving all the time, and people are moving all the time. What we experience today is that there is no much research in urban settings because it's much more complicated, but as well, health interventions in urban settings are much more complicated. But there is no alternative. We have to do it. In Lebanon, in Beirut, there are many refugees who are actually in the city. They're renting rooms, renting flats, renting studios, and they live within the community. The challenge for humanitarian organizations is to reach these populations, to keep contact with them, making sure that they get access to information about access to care, or as well simply making sure that they come back when they need to come back to the clinic, or we can reach them through our outreach services. So it's a new challenge again, and we're talking about the high numbers of people. Today in Greece, people are rehousing refugee families who used to live in camps, and they're moving them into flats. Why? Because living conditions are going to be better. They are suffering from the winter. Second, for the security and safety is much more important. Making sure that we know that they're in a safe place and they have more security, and as well to get access to local services, making sure that around these flats and these accommodations they get access to services. What we've seen in Greece, for example, in Athens, and it's not well documented, is some very good initiative from the Greek communities, where actually when they know that refugee populations are around them in flats, in houses, they actually provide free time, they provide donations or food or clothes, making sure that these newly arrived refugees who do not speak a word of Greek can actually get access to the right services, social services, education and health, and making sure that they're not lost. And I think it's these dynamics between populations, that's very, very interesting. This needs to be documented. We need to work more in this kind of setting.
think that's a very interesting point because with all the shortcomings of having camp settings, the thing that was actually very much much easier to deal with was that you would know where people were, you'd know how many people were in the population. I mean, the census data from a camp is like you will get nowhere else. I mean, they know how many people are there, and that's really useful in terms of planning for services. What we're seeing is a much more chaotic, sort of messy setup now, but people's needs remain, and really the challenges now, and particularly with the Syrian crisis, is very much more disparate and chaotic, and it's really about being able to adapt to that change. And I think there's a role there for technology, with mobile technology and those sorts of things, to be able to better manage those new challenges. Okay, so our next question is to ask about balancing and respecting the culture and priorities of affected communities and the need to follow humanitarian principles of impartiality, inclusion, and ensuring you serve the most vulnerable. Should I kick off, or would you? I would say this is crucially important, and I think Carl would, and any sort of humanitarian practitioner would agree, is knowing your context. What are the social norms and values and politics of where you are? It's really crucial. It doesn't matter if you're working in health or protection or education or whatever. I think, you know, we have seen situations where Ebola, again, is another good example, where there was a really huge rush of people into the West African countries, but without necessarily a very good appreciation of cultural values. And I think where we see this very, very clearly is around burial practices and how important it is for families to wash the bodies of their loved ones once they've passed away. Which of course makes them highly vulnerable to transmission of Ebola. This was a really key thing about learning about social norms and social behaviour and getting a sense of how to promote behaviour change around burial practices. And that's really where anthropologists really came into their own during the crisis, because they were able to see things very clearly from the perspective of people and what mattered to them. And there was a whole campaign of behaviour change around that, which had imams and other religious leaders working together and almost giving people the sort of leeway and the permission to change the way that they buried their loved ones, and to reassure them that this wasn't them not carrying out their sort of family obligations, and that it was necessary in this really difficult and unusual time. I think another thing to consider is also what type of work you're doing. And in the health sector, there are many issues that are very contentious and stigmatised and fraught with issues. I've worked predominantly in HIV and sexual health, and that can be tricky in many, many situations, but it's particularly tricky where you're in a socially or religiously conservative country. And the realities of transactional sex, sex for money, intergenerational sex, child brides, also issues around stigmatisation of STIs and HIV are very prevalent. It's very, very difficult often to even discuss issues about risk of transmission and how to prevent it. I think you have to have a very, very careful and considered approach, but at the same time being committed to supporting vulnerable groups, because often it is very vulnerable groups that are most at risk. And I think there's even things that at first glance may not seem very contentious, things like polio vaccination. In Somalia, in Pakistan, in Nigeria, vaccinators have been killed because there's suspicion around the vaccines and that they're actually poisonous, and that it's a campaign to kill people in that country. And at the time when I was in Somalia, there was a number of people who were vaccinators being killed by Al-Shabaab. And this really brought home that, you know, it's what you may think is a very sort of routine administration of healthcare prevention actually is rooted in a very political agenda, and you need to be aware of that, both to protect the people that you're working with, that are implementing, but also somehow being able to give people access to provision if they wish to have the vaccine. So I think culture and sensitivity and understanding are really crucial overall.
Yeah, no, I fully agree. And then doing the Ebola crisis, we realized how much we had misunderstood or not, or we failed to understand anything about local communities, and we created fear rather than acceptance of interventions. It was how do you say that, a key finding. But I think in the humanitarian sector, and I'm not completely against it, I'm very much in favor of developing clinical guidelines. It's very important. Very important to make sure that we give guidance to all humanitarian relief workers, making sure that we deliver standard or effective interventions. However, I think we have a lot of blueprint interventions that are often not really adapted to the context. And what I would say is that there's a lot of improvements, and I can see that we have really understood how to better take into account into our interventions the local context and culture. I'll give you a couple of examples. One is about the UK outbreak rapid support team. So basically, the UK government has decided to create a rapid support team to respond during outbreaks after the Ebola. And we have a 10-person team managed by Public Health England and the London School. And at the London School, one of the 5 people of our team is a social researcher. And that's based on what we learned from the Ebola crisis. A social researcher who is going to be able to prepare a brief before departure, looking at what has been produced and investigated on local culture and knowledge, but as well who is going to investigate during outbreaks what communities perceive on what is a perception on the outbreak, on the disease, how they perceive the responders, how they perceive the researchers who often come to do trials, for example. So what I want to say that, yes, it's very important, and I think we more and more understand that it is a key element of our response, and that's a good example. Another example we are looking at, we are starting a new study in Lebanon on culturally appropriate care. We realized that Syrian refugee populations preferred to go to a Syrian doctor rather than to a Lebanese doctor in the Bekaa. And this asks questions about why do they choose Syrian doctors rather than Lebanese doctors? Where does that come from? And interesting, this notion of choice as well. How do they make such decisions? And so we want to understand culturally appropriate care that has been investigated extensively amongst asylum seekers in Western countries. So we have a lot of evidence, for example, in Sweden, in the UK, in Denmark, in France, in Germany, that so many populations have difficulty to actually use healthcare providers in Sweden and other countries, just because what we understand is that they do not have the same perception of what a healthcare provider should do, and that's very important. So what we're trying to do in Lebanon is actually to look at life stories of refugees to really understand who the patient is. So what we're trying to do by this notion of culture is actually not only in terms of the group, but as well the individual. How do they perceive their body, their health, and the providers? And how do they see their position within the community? And how does that influence the decision to choose or not a provider. And that's very interesting. So I think, yes, culture is a key issue. We need to work on blueprint interventions, but they need to be adapted to local culture. That's obvious. It is very challenging. I'm not saying that if we don't do it, it's because people do not want to do it. I do understand that it requires that we investigate, that we understand and take time to understand local communities and the perception. And that's quite challenging, I can admit. But it's a trend, and I think we're going toward that. What does that mean for all of us? Is that we will probably need to retrain our medical doctors, our nurses on these aspects, making sure that they take that into account, but as well all the relief workers, making sure that's part of the training. And for the moment, it's not. It's very much on medical care, very much on public health. I think the culture needs to be more at the center of the training and the interventions.
Okay, thank you, Carl. We have one more question, and that is on transitions and moving into the recovery phase. So the question is, when an acute crisis ends, how is the transition between crisis response and development coordinated? Are there cases where this is smooth and successful, or are they chaotic transitions? So I think we need to just sort of revisit the kind of objectives and content of the MOOC. Our MOOC's very much looking at the initial response and the time thereafter. But in a humanitarian crisis, as we've seen in the case studies throughout the course, these are often very protracted, particularly the ones that are conflict affected. They can go on for many years or even decades. And so the process to recovery is quite different. What we're looking at in the humanitarian response, and many of you had questions and comments about this in different steps of the course, is that it really is about life-saving in the initial phase. And that's why there are specialist organisations that go in, and that is what they do. That's their USP. They go in, they are very much looking at saving lives and making sure that illnesses are dealt with very quickly to prevent further deaths. This, of course, will transition as the acute phase winds down. Our course has very much been focused on that part of crisis response, but there's the longer journey and the longer transition of a country going into recovery. And people often say, well, when is the recovery period? I think for a natural disaster, that's usually fairly soon after, in a matter of weeks or months. Whereas in a conflict-affected setting, it can be decades. So you've got civil wars such as Somalia that have been going on for over 2 decades. Northern Nigeria, Pakistan. I mean, these are crises that are a long-term thing. What we'd really need to keep in mind is that even these sort of initial responders and the people that go in a humanitarian context, part of that work is the planning for the recovery period and the planning for the transition. In something like a conflict-affected setting, let's, for example, take South Sudan when it went to gain independence from Sudan, what would need to be in place is some sort of stabilisation and an increase in security. And that would be the foundation for doing post-conflict assessments and planning and a transition phase. What that involves is quite a very involved process of rebuilding a nation in some cases. And when we look at that from the lens of health systems and healthcare, for some countries, many countries in fact, it can be about building back better. And in fact, they didn't have a functioning healthcare system, and it's about how to start again and how to build back better. Now, that requires many different things. There has to be health financing. When a country goes into transition, what kind of funding they're eligible for changes because they've come out of a humanitarian crisis setting. And there's usually a transition where more money needs to come from the government themselves in order to provide those services. But you're looking at incredible challenges in many countries where there has been protracted wars, and with that has been perhaps many deaths, or the most educated and qualified people have either died or they have in fact fled the country, and there's been a massive brain drain. So things like staffing your healthcare workforce becomes incredibly challenging because your best qualified people have left or died, and you also don't have a functioning education system. And to get people qualified into the workforce will take a number of years as opposed to weeks or months. So we see massive, massive challenges to make that happen. We can also look at recovery in the sense of where we might think it might be a little bit easier, where it's not in a conflict setting, and see that there's many challenges with that too. If you look at the earthquake in Haiti, which was in 2010, we're now a number of years on, and Haiti's seen as an example of where there wasn't a lack of funds, and there was actually quite a big international response that was quite quick to have boots on the ground. There were criticisms about the leadership and coordination of that, but now 7 years on, what we see is that there are still tent camps. So 7 years after the earthquake, people are still living in tent conditions, and we're talking about tens of thousands of people 7 years later. Now, that seems like something that if the money's there and if the political will's there, if the international aid is there, why is that the situation now? And it goes to show that it's incredibly complex to make that transition, and there's been public outcry globally about why that situation still remains, but still people are essentially living in very, very poor conditions that affects their health and continues to, because they continue to be at risk of infections of close and poor quality housing. So I'd say in summary, the transition period is just as important as the initial response, but actually building back better and getting people back to health is a really, really challenging thing to achieve. Do you want to add anything?
Yes, just wanted to add some current work we are doing on the health system. So we're not looking at communities as such, but we're looking at health systems. And we're looking at this notion of resilience. And basically, we are trying to measure a resilience index in order to be able to anticipate how the health system is going to absorb or adapt to a shock. And a shock for us is a humanitarian crisis. So basically, we're looking at what capacities they have at the start, that these are the assets, and the stocks, if you want, and we're looking at all the flows that Adrienne was talking about, the movement of people going out, all these professionals migrating, but as well the flow of money coming in, going out, and so on. All these flows are very important. So we're trying to measure all of that and taking into account the intensity of the shock, for example, the crisis, the war, the armed conflict, and trying to understand how this health system is going to be able to absorb the shock or not, or is going to adapt to the shock, in a sense that I'm going to be able to call on new resources. I'm going to remanage or redistribute my resources within my health system. So basically, if I'm short with doctors, maybe I'm going to do some task shifting to be able to respond to the crisis, and so on and so on. I think it's when you think about the fact that when a country experiences an armed conflict, it is very likely is going to experience another conflict within 10 or within 15 or 20 years. So you need to be ready anyway to reconstruct your health system to respond to what can happen. And I think it's the Ebola crisis where we did a lot of studies on resilience, and we demonstrated that the health system in Sierra Leone, for example, was not strong enough to respond to this type of crisis, and that all these health system strengthening programs that have been put in place had not been good enough, not been strong enough or serious enough to actually build the capacity of the health system. It make us think about where do we need to invest the money? When do we need to invest our efforts to make sure that these kind of health systems who are likely to experience this kind of crisis are going to be able to absorb the shock that is coming in the next few months or few years. And I think it's one of the key gaps. But I think quite a few researchers at London School, in our group, but as well in other institutes, are trying to make sense of all of that, making sure that we can inform better all these investments into the health system.
Great. Thank you, Carl. So we have one final question. This may be our favourite one because we get to talk about London School quite a lot, and also personal experiences. So the question is, how do you start a career within the humanitarian sector? After educational credentials are complete, how can we find entry-level positions with major organisations? Do you like to start? Or?
Yeah, so I think, when we started this MOOC, it was very much about people were asking us, why do you want to do this course? You need to justify that. So we need to, a lot of resources have been invested in this MOOC. A lot of people have worked on this MOOC. And of course, we had to justify why it is important to do it. One of our key arguments was that we need to inspire a new generation of professionals or newly graduated people who want to work in this sector. It's very important that you come and work in this sector and make us benefit from your skills. But of course, it is very challenging for you because to get your first job is very challenging. And I remember this a few decades ago. For me, it was quite a challenge, and I had been very lucky. So what I would say is that you need to work on this luck, and you need to push for it. What I'm saying is that you have followed this course, and it looks like many of you had been quite interested in the content and what we talked about. If you're inspired by that, you need to force it. And I receive many emails or many requests from young people who want to work in this sector. We are probably, as London School, probably not the right people to offer opportunities. And I would suggest go and do some field experience. This is where you learn. And of course, to get this first field experience, that then going to give you the next job and the next job and the next job and so on. It is very hard. But I think you need to keep pushing. And people are always interested in people who have a lot of energy and who have the skills to deliver. Get your degrees, that's very important. You need to be qualified. You really need to go to the end of your studies and be qualified. So if now you want to work in a certain sector, you need to be graduated. It's not like me where I remember we used to have orthopedic technicians. They were becoming orthopedic technicians, but they used to be garagists. We didn't have the right qualification around us, so we had to improvise. But now we live in a different world. It's the 21st century. We are only recruiting people who have degrees, and you need to really go to the end of your studies. But then you keep pushing. You have to lobby people. You need to demonstrate that you want to do it. And you will get your first opportunity. Either it could be an internship, it could be a training, it could be some volunteer work, or your first job. But I'm sure it's going to arrive, it's going to come. But what I'm saying is that it's very important. We need more and more people to work in this sector. It's very important. You've seen throughout the course how many needs have not been covered because we do not have enough resources. We need more and more professionals to come and help in this sector. And I think it's very important that you take that into account. The London School is a public health institute. So we offer a lot of courses in public health. So you can go and look at all the master we offer. It's quite a wide range of qualifications. In Humanitarian Crises, we offer the distance learning master. That's something you can look at. But as well, there are quite a few short courses we are going to organize throughout the year. And I think what is important for you is to keep an eye on the website or subscribe to the newsletter. there are quite a few short courses we're going to organize. 5 days, very short, and sometimes they could be organized in your country. This is what we want to do. We want to organize training of professionals where they work. So we are planning to organize courses in Beirut. We're planning to organize courses in Nairobi and in Kabul, for example. And they are meant for you. Very short, very intense, and that's another qualification for you.
I would say, to add to what Carl said, one of the things that we did in the course is that we saw how increasingly the capacity building within the humanitarian sector has become increasingly professionalised. And not to give our ages away or anything, but I think things were very different when Carl and I were younger. And I think that, 20 years ago, there were very few courses that focused specifically on crises, whereas now you see quite a number of courses, particularly at the master's level, where you can go and study those things. I would really support what Carl said in the sense that you do need to have qualifications and some sense of expertise. Now, your expertise could be very wide-ranging. If it's public health that you're interested in specifically, you could be an anthropologist or an epidemiologist or a clinician. There's lots of different applications. And then one of the wonderful things when you work in a humanitarian setting is all the other different people that are there. So you have a lot of the protection people will have a law background, for example, plenty of engineers and people that dig ditches and explode mines and all those sorts of things. So there really is a huge wealth and very, very wide-ranging set of skills that are needed in humanitarian crises. I think investigating and having some sort of foresight about what interests you and how you think that could be applied will be very insightful and instructive in how to pursue that academically. But the academic side alone isn't enough. I think one of the things that is very clear, and I think when we've been in positions where we've been in country recruiting people, for example, or looking at people to work with, is a passion for humanitarianism and the principles, because there are many dark days. Not every day is a success, not every day is a happy one. I'd say in the humanitarian sector, probably the ratio of good days and bad days weighs more on the bad days. But the successes can be phenomenal. And I think if you could have that perspective and that passion to be committed in the beginning, but committed also when it gets really tough, I think that's very, very important. So personal resilience and a real vision of what you want to achieve are very, very important. I would say that the mindset that you may have to have is one of respect and integrity to go into this work. I think that in the past, sometimes doing humanitarian work or charitable sector work has been seen as sort of Western people going and giving and instructing and that sort of thing. And I think that mentality won't get you very far. The humanitarian crisis settings are much more sophisticated. They're much more intricate. They're much more about building relationships and alliances, and going in with a kind of more arrogant attitude really isn't going to work. And so I think, as well as the academic things, you also have to think about your personal qualities and how you like to approach work and how you can work with lots of different people. And that includes people that are on the other side of a political divide or don't observe humanitarian principles or respect groups that you're trying to protect or serve. So I think having, developing a lot of resilience around that is incredibly important. And I think you have to have a skill set to take with you. And again, that needs to be the academic side, but I think it's really important to get that first-hand experience. And that can come through things like volunteering. It can come through internships, or starting off perhaps not in the ideal position you'd like to be in, but with a trajectory to move and to get more experience to get your way along.
Excellent.
Do you have anything to add?
No, that's very good. Excellent.
Okay. I think we're going to leave it there for now. We hope you've really enjoyed both the course and having this Google Hangout. There's a number of resources that we will post online to you that we have mentioned today, which includes papers and references and also our courses. So as Carl mentioned, we have online courses, we have courses that happen at the school, or perhaps they can be courses that are in your home city or town. So we will leave it from there. We'll say thank you very much for your involvement, thank you for your questions, and we look forward to you completing the course.
Thank you very much.